Hi, welcome to the 2021 SCTS. I've got great pleasure in being a part chair of this session, which is MDT engagement and success stories. And I'd like to have the pleasure of introducing our first speaker, who is Fiona Nolan, who's going to discuss mobilisation on intra-aortic balloon pump, and the sessions will run subsequently following that. There's one missing session, which is session 3, and I'd like to have the pleasure of introducing Fiona.
Thank you for this opportunity to speak about our experiences of walking patients on intra-aortic balloon pump. Golden Jubilee National Hospital is the home of the Advanced Heart Failure Unit and the only centre in Scotland to carry out heart transplantation. Over the last few years, we noted anecdotally that we had an increasing amount of patients on balloon pump for a prolonged period of time whilst awaiting transplant. Our standard practice at NHS Golden Jubilee was these patients would remain on bed rest until transplant. For a physio point of view, patients would receive a maintenance programme including basic exercises, deep breathing exercises and a bed bike regime. As per manufacturer's guidance, hip flexion was limited to 30 degrees. But as physiotherapists, we considered what else could we do. Our VAD programme had started in 2011 and we began to mobilise our patients in 2012. Our team discussed this and we began to research the possibility of walking this cohort of patients. Although this was not advocated by the company, this was not normal practice, and there was some scepticism within the MDT, we began to engage with all the stakeholders. Our process began with researching journals where we found some articles describing relevant case studies in both the United States of America and Norway, which assured us this could be done safely. We developed a robust protocol, which supported by cardiologists, the MCS team, our surgeons and our nursing staff. We developed a stringent risk management process, which was reviewed by our clinical governance team to board level, as this was a completely new practice. This is George, who consented to be our pilot patient and has very kindly agreed for us to share this image. Our protocol dictates that we have 2 members of the physio team and a member of the nursing staff for safe mobilisation. Throughout George's treatment, he did very well. He was on a balloon pump for 16 weeks prior to transplant. His personal best was walking 5,650 steps, which was equal to 7.1 kilometre in 1 day over 2 sessions. During his waiting time, he was weaned from milnirone due to improvement in right heart catheter data. He was transplanted on March 2nd, 2019 and was extubated within 12 hours of his transplant. George had met all his physio goals within 11 days and was fit for discharge, and finally discharged from the hospital on day 18 post-op. To date, we have mobilised 14 patients who have spent a combined 1,177 days on balloon pump, ranging from 11 to 209 days. This resulted in 1,014 physiotherapy mobilisation sessions with no adverse incidents noted during mobilisation. We believe that our patient outcomes have supported this intervention. Unfortunately, we did have 3 patients who passed away prior to transplant and 1 patient who passed post-transplant. The remaining 10 patients discharged safely home on an average of 19.9 days, with a range from 12 to 38 days. Of these patients, 8 mobilised day 3 or below, and this is now standard practice at the Golden Jubilee. So our next steps, we've already shared this protocol with Blackpool and Manchester physiotherapy teams. We hope that this will become gold standard treatment for all long-term patients on intra-aortic balloon pump whilst waiting transplant. Our team won the Scottish Government Award at the Advancing Healthcare Awards 2020 for innovation and demonstrating impact. And we were also lucky enough to win the NHS Golden Jubilee Chair Award for innovations. I'm happy to take any questions and have left a couple of testimonials from our cardiologists who I believe are very impressed and very happy with the treatment that our patients now have. Thank you.
Hello, my name is Sean Griffiths and I am a Senior Physiotherapist at Cardiff and Vale University Health Board. Today I will be presenting on the following title, Enhancing Physiotherapy Input to the Thoracic Surgery ERAS Pathway, Effects on Mobilisation, Length of Stay and Post-op Pulmonary Complications, a Quality Improvement Project. ERAS protocols as a strategy to improve patient outcomes have been discussed as early as 1997. It refers to a combination of perioperative interventions, a minimally invasive surgical approach, and MDT working. The main aims are to reduce post-op pulmonary complications, or PPCs, length of stay, aid return to functional level, and minimize the impact of surgery on patient recovery. Research shows that thoracic surgery can directly impact the respiratory function of patients postoperatively, which leads to a relatively high risk of developing PPCs. At the Cardiothoracic Centre in University Hospital of Wales, Cardiff, a local physiotherapy audit was completed to collect baseline data between October and December of 2017. An ERAS pathway was then introduced to thoracic surgery in April of 2018 as a WISC initiative. Following an initial settling in period, a physiotherapy quality improvement project was completed between June and August of 2018. The main aims and desired outcome of this QI project was to reduce PPCs and length of stay and reduce time to mobilise in all post-operative thoracic surgery patients. We aim to implement increased physiotherapy provision, early mobility and promote MDT working. Prior to ERAS implementation, physiotherapy input was decided on a day-to-day basis according to patient need, but could be increased if respiratory compromise was noted. Patients were seen once daily on day 1 and then every day until independent or discharged. Following ERAS implementation, all patients undergoing thoracic surgery were seen on day 0. A physiotherapy evening service was started to complete a respiratory assessment and aim to sit patients out of bed or even mobilise that evening if appropriate. Patients were treated 3 times daily on days 1 and 2 post-surgery. Following this, the patients were seen once daily until independent with chest care and mobility. Again, if respiratory compromise was discovered, increased physiotherapy could be provided, or a box step or static bike could be used to challenge patients further. In addition, incentive spirometers and a patient exercise diary were used to promote independence in their recovery. Demographic data was not statistically analysed or compared. This chart, however, shows the 5 main demographics reviewed during this QI project. It is interesting to note that the median age was similar in both groups, however the ERAS group demonstrated a higher number of males when compared to the baseline group. The short physical performance battery test was also completed at preoperative assessment clinic to assess baseline mobility, function and limitations. Both groups showed the same median result of 11 on the SPPB. However, we did not find any correlation between those scoring lower to reduce time to mobilise, longer length of stay or higher PPC rate. In addition, it is important to note that the number of current smokers at pre-assessment clinic in the ERAS group were much higher than baseline, 38% versus 13%. A post-op pulmonary complication was diagnosed using Brooks-Brunn classification. PPC rate increased marginally when comparing baseline to ERAS data, 9.7 to 10.3%. However, it is important to note that the number of current smokers in the ERAS group were much higher. Research shows that thoracic surgery patients who continue to smoke up until surgery have a higher risk of developing a PPC in comparison to non-smokers. In addition, they can also experience an increased length of stay and a greater readmission rate to ITU. It could be concluded that we should have expected a higher rate of PPCs in this ERAS group due to a much higher rate of current smokers. However, with only an increase in 1%, it could be suggested that the implementation of ERAS into thoracic surgery, which included increased physiotherapy provision, could have helped to maintain the PPC rate in a group that showed higher risk. Further results, including days to sit out of bed and mobilise independently, were not statistically significant when comparing both groups. However, it is great to note that the ERAS protocol reduced length of stay from 5 days to 4 days and therefore saved a median of 1 hospital day. It is important to also note that this QI project has limited external validity due to a small sample size and short duration of data collection. Sadly, since the outbreak of COVID-19, our cardiothoracic centre has experienced great change. It would be beneficial to complete a full MDT review to ensure we are continuing to achieve the core principles and aims of ERAS. It would be interesting to also liaise with other centres as to their options for providing pre-operative assessment and post-op physiotherapy care. Many thanks for listening. Please let me know if you have any questions.
Hello, I'd like to present to you our project called Life After Lung Cancer Surgery. My name is Lisa Kenyon and I'm a Macmillan Thoracic ACP. The aim of the project was to improve outcomes for patients who'd undergone curative lung cancer surgery by delivering personalised care and support planning and surveillance pathway led by ourselves, the Macmillan Thoracic Surgery ACPs. The issues with consultant clinics were that there were very long waits for appointments and also in clinic. There was patient anxiety, having to have time off work to attend clinic. There were costs involved, and generally a relative or friend would also accompany the patient, which also inconvenienced them. There was a lack of adherence to the follow-up protocol. There were unreported and unordered CT scans prior to the clinic, which resulted in a wasted clinic slot. The idea was also to support the lung cancer nurse specialists in meeting unmet needs of surgical lung cancer patients, which had previously been reported. The radiological part of the project was to follow the current CT surveillance recommendations for resected lung cancer, to set up and audit the pathway with clear targets, and to take over CT follow-up from the consultant surgical clinics over 5 years. This would release consultant time to see new patients and deliver post-op diagnoses, to deliver shortened diagnostic and treatment targets, and reduce the need for face-to-face follow-up in clinic appointments. The objectives for the personalised support elements were to improve recovery of quality of life after lung cancer surgery, to improve patients' general health and well-being, and to tailor care for patients through a holistic needs assessment, which would be revisited at every appointment. Also to signpost patient to sources of support, such as the Macmillan Helpline. Our solution was to instigate an ACP-led virtual clinic for CT surveillance. Examples of virtual clinics are good practice in the National Lung Cancer Audit, and these initiatives have allowed increased clinic capacity with minimal cost to commissioners. There were basically 2 arms of the pathway, but the whole pathway is much more complex than this suggests. The first arm was a holistic needs assessment and addressing specific needs that the patients were bringing up, and then to signpost or refer on to recovery package measures such as exercise or rehabilitation and smoking cessation. There was also the monitoring pathway with CT surveillance and symptoms, which we would address in each appointment. We got Macmillan funding for a patient information leaflet, which had a section about signs to look out for, sources of help, and also a chart so that they could keep track of their CT scans and blood tests. The results were that we recruited 183 patients. 100% of these have had an HNA, and all have been signposted to the Macmillan helpline. And there were a further 22.2% who had further needs which needed signposting on or referral on to other services. The post-op range of the patients were lung cancer surgeries from range 2014 to 2020, and all were stage 1 resected non-small cell lung cancer. 10 of these have been referred back to MDT because of signs of recurrence. We did a satisfaction survey and found that 99.5% of people were happy with a virtual or telephone clinic, and 277 clinic slots have been saved in 18 months with our pathway. In conclusion, the ACP-led virtual clinic addresses the cancer patient-centred follow-up agenda and addresses the health and wellbeing needs of lung cancer survivors in our service, and is popular with patients. It saves clinic time and cost, thereby improving efficiency. We plan to develop and extend to the off-site clinics. We plan a navigator role to help with signposting and referral on. And we are also involved in developing a Fit for Surgery app, which will also support patients in their recovery after surgery. Thank you for listening. Are there any questions?
Hello, and thank you very much for the opportunity to share with you the development of our project in Brighton, where we're going to look at the impact of a 24/7 ACP service in the cardiac unit, working across the ward and the ITU for cover for 24/7. And I've also included all members of the team, picture on the right-hand side, but also what success looks like, because part of our team also working in theatres are our surgical care practitioners. So just in summary, the team consists of 8 ACPs who have now all moved from the trainee to the qualified position, all obtained their PG Cert and PG DIPS, and they're all non-medical prescribers, and they are now all embarking upon their dissertations. Some are significantly through it, and some of the projects that they're doing from a service development point of view underpin this presentation. We also have, as I said, our 2 surgical care practitioners working in theatres who are now fully qualified as well. In terms of the successes across the 4 pillars to designate the advanced practice level that everybody is working at, apart from the clinical area where everyone is working in conjunction with the joint MDT, with advanced skills and the decision making for the patient management throughout their journey, we also would like to talk about the achievements in the educational pillar. So the team have all been attended and then been faculty for national courses that the SCTS run, and they have been successful in securing 2 of the SCTS INSQ fellowships, both in 2018 and 2019, which have very much contributed to the development of the service and the projects that we're about to discuss. They have also been on a national and international forum with presentations of their work and won a Best Post Award at a local regional meeting. In terms of the impact, from a research and audit point of view, we're going to share the preoperative iron optimizing service delivery that's been developed, the lung ultrasound study, and then the service that's been developed, and the development of the ward attendee service so that patients can have a reduced time in terms of their hospital stay. Moreover, we've also looked at our ward rounds and the audit of the structure of review and improving quality and consistency for patients. And then how have we captured the pathway, I suppose, for the team becoming increasingly independent. And for this, we've used the Nottingham model for phone calls at night, as this team are now sit on the reg rota in the sense that they are the first on call at night, and we have non-resident registrars. Throughout all of these 3 pillars, we can see that the team have really had a big step into their leadership of self, leadership of service, and leadership of their pathway into advanced practitioners. So we've seen them come to sort of fruition and grow and have a real impact on the service and the unit that we work in. So if we just start with the day case service, we've created an electronic referral process that is completed by the ACPs at discharge. At the time of data collection, the number of patients referred had been seen and captured over a 4-month period, a total of 25 patients, of which 2 had been seen by SPRs and 23 had had their episode dealt with by the ACP. In terms of their presenting history, these patients were looked at from a wound review point of view, chest x-ray review, blood test follow-up and rhythm issues. And the actions that resulted in the ACPs and the 2 patients seen by SPRs covered prescription for antibiotics, changes in their medications, review of wounds and what was necessary, and in some cases no action was required but reassurance was certainly given. And all these things have contributed towards earlier discharge of patients, prevention of visits to our ED department and prevention of readmission. The project on optimising preoperative HB has identified patients during their screening at pre-admission clinic, and at the time of data collection over 120 patients had been identified with either non-iron deficiency anemia, for which further investigations and follow-up were instigated, and also iron deficiency anemia, which has meant that we have had a weekend attendance for supplements in terms of infusions to be able to augment that HB prior to surgery, which we know evidence suggests gives better outcomes. So we have been able to demonstrate that, and one of the team is using this as forming their dissertation. The ultrasound service that we have developed was based around an education program that one of our consultant anaesthetists did with us, and then a formalising an assessment form and a accurate documentation of findings and process. And in order to test the ability of the practitioners and their interpretation of the ultrasound, we had a number of patients where we also performed a chest x-ray, and the chest x-rays were independently reviewed by the consultant anaesthetist. The results of this showed that in 84% of the patients and the scans we had joint findings and everything was underpinned, but moreover it also gave detail that when the ultrasound was then looked at by the consultant, the additional information that the clinical practitioners had also provided was seen on the ultrasound but not seen on the x-ray. So we are very happy that this service is being able to function and accessed earlier for patients by the bedside as well, without all the effort of moving them. So in terms of the Nottingham model and looking at night calls, we also reviewed how many calls were made once the ACPs were on their own at night, with the structured 10 o'clock call at evening for the consultant anaesthetist and the consultant surgeon. So the registrars became non-resident and the calls were monitored, and essentially what this slide demonstrates is what they were called for moved from medication and drug product issues into things that actually needed to either just be communicated or that the patient needed a further team to be called in. So the number of calls have gone down, and the number of events that required people to come in have also reduced, but also are very appropriate for the clinical condition that's presented. So to look at the service overall in terms of how it's helped with the ward round and a structured approach, we thought we'd do a 360 review. So starting with our patients, they commented that they felt that it was a consistent ward round and a consistent team with good communication, and that the team members were approachable and listened to what they felt was important. Our bed manager felt that the patient flow had improved. Consultant anaesthetists have enjoyed and felt that it is a positive move forward and are very happy to look at reconfiguration of roles. The ITU and the ward nurses had suggested to us that the patient engagement with them and a daily plan was very helpful, and that the team themselves were accessible and willing to teach. Pharmacists had noted that the accuracy of TTOs was good and less mistakes. Physiotherapists noted that the team were visible and consistent, and they helped with patient plans. Our surgical trainee colleagues felt that it did augment training opportunities outside of service delivery. And our consultant surgeon team felt that we were rapidly becoming an asset to the service, and that there needed to ensure that we move forward and that the service remains. So we'll end the presentation there, and I will open up for questions, and thank you very much.
For coping with this technology that we're all learning about. I'm just told that I'm on mute. Can you hear me? I'm just waiting for, yeah, I think I can be heard now. So apologies if I was muted there. I just wanted to welcome everyone to the meeting, and saying that we're just taking a slight pause at this stage to consider the excellent presentations that we've just heard, and to also just remind everybody in the audience that there is an opportunity to ask questions to our speakers. We'll have a question and answer session at the end of the whole session, where we will invite speakers to the stage to take your questions. And these can be done on Slido, which you should be able to access from your devices there. So I'm just going to say a little bit about our next two presenters. First of all, it's a pleasure to introduce my very dear friend, Bernie Deer, who is going to talk about a phenomenal experience that she was involved in at Papworth Hospital when the hospital moved from a very sleepy little village in Papworth Everard to a brand new state-of-the-art purpose-built hospital adjacent to Addenbrooke's Hospital in Cambridge, onto a biomedical campus. So we very much look forward to hearing Bernie's presentation. And then straight on from after Bernie has given her talk, we'll be hearing from Felicia Kwaku, and it's a real privilege to welcome Felicia to our conference. Felicia is an Associate Director of Nursing for Quality Improvement at King's College Hospital in London. And she's also chair of the Chief Nursing Officer's Black and Minority Ethnic Strategic Advisory Group for NHS England. Now, Felicia supported Black, Asian and minority ethnic nurses when it became clear that these groups were being disproportionately affected by the pandemic COVID-19 virus. Felicia delivered webinars which reached thousands of nurses at a time when they felt vulnerable, scared and worried. And Felicia has spoken up loudly and decisively about the need for appropriate risk assessments and PPE for nursing staff and other clinical colleagues. And in recognition of this work, Felicia was awarded an OBE in the Queen's Birthday Honours list in 2020 for her services to nursing. And for those of you who were present in the plenary session earlier in the auditorium, you'll already have heard Felicia speaking about some of her work and some of the staggering statistics that she identified. In this session, Felicia will be talking about making the impossible possible. So we will look forward to hearing about that. So again, just if I can remind you, please, to submit any questions that you might have onto the Slido, and we'll be looking at those as we go along, and then we'll be taking questions and answers at the end of the session. But for now, I'd like to introduce Bernie. A very warm welcome to you, Bernie. Thank you.
Hello, my name is Bernie Deer. Thank you so much for accepting my presentation to share with you today. 5 minutes will not quite do this justice, but this is my personal reflection on moving our critical care from Old Royal Papworth, situated in a sleepy Cambridgeshire village, to our brand new purpose-built home right beside Cambridge University Hospital. This all happened in May 2019. Old Royal Papworth was a very special place to many. It originated in 1918 as a TB colony and went on to become a world-famous cardiothoracic hospital responsible for so many amazing firsts. 101 years later saw the long-awaited move to our state-of-the-art new build, and many now felt that this building matched the prestigious work that we did. So our straightforward journey took us across Cambridgeshire, approximately 24 minutes, 16 miles from old to new, taking in a section of the M11. As one would expect, many meetings occurred prior to move date, looking at how we would continue to provide our service to our patients throughout the move, looking at potential numbers and the pausing of our ECMO service. Being given autonomy very early on by my manager was hugely beneficial because it meant I could really use my clinical knowledge in the planning. I decided to use a dedicated transfer team for the move, made up of ECMO retrieval nurses, senior medics and perfusionists, all used to transferring the sickest of patients. With the ECMO service on pause for the move, I was able to utilise the private ambulances we have and the familiar drivers, and taking the bedside nurse across from old to new on that transfer meant for greater continuity and avoided lengthy handovers. We obviously had to plan for the worst case scenario, so the sickest of patients, it's like somebody with an open chest post-surgery, so we had to consider equipment for that. We had a command and control centre on both sites to make sure, obviously, of a safe process throughout. We worked out 100% oxygen for all of our patients because we thought this would be the safest thing. And we made sure that we had a very smiley and excited team welcoming each transfer on the new site. We then in March, 2 months before move day, did a dummy run with some of the team just to ensure we could iron out any problems. And I was pleased to find out we had no problems. So move week arrived and we realised we had 2 BIVAD inpatients awaiting transplantation. And very sensibly, the team decided it would be much better to move these patients earlier than the planned move date, as it was felt it was much safer for them to be stable preoperative patients at New Papworth rather than potentially very sick patients at Old Papworth. And this is one of them, cutting the ribbon on arrival at New Papworth with the team. And then as the week progressed, we made sure we had the order of the patient's moves in place. So on the day itself, the day was actually quite unforgettable. The teamwork was incredible, so much so that we completed the move in 1 day instead of an estimated 2 or 3. We moved a total of 9 ITU patients that day, using 2 teams and 2 ambulances with staggered leaving times. Emotions, as you can imagine, were high, and at the end of the day, seeing our unit empty and silent was quite surreal and eerie. And as you can imagine, saying goodbye was not easy. I'm sure there are things that we could have done better, but looking back, it was a smooth and successful move. But I did realise that we should have structured something to allow for more staff to come back to say goodbye to Old Papworth, because for some of them it had been their home for over 30 years and it was a truly unique place to have worked. It just felt that very quickly it needed to be locked up and made secure, offering little time for staff to return. I want to share with you, this is the video of our final patient's transfer. So that's it. Thank you for listening. And if I can answer anyone's questions, I will try my very best. Thank you so much.
Hello, everyone. My name is Felicia Kwaku, and I am one of the Associate Directors of Nursing at King's College Hospital, and I'm also the Chair of the Chief Nursing Officers for England, Black Minority Ethnic Strategic Advisory Group. And today I'm going to talk to you about making the impossible possible, nursing whilst Black. And I say this because for Black or Asian or ethnic nurses to reach the dizzying heights of their careers is often fraught with obstacles, and the kind of markers are very different for us. We normally have to work twice as hard to get half as far as Yvonne Coghill says. So this is my journey. So I want to start with my history, my background. This is my history. I'm from Nigerian stock. This is my mum and dad on their wedding day. And in the middle, the pictures of my maternal grandparents. And my dad came over here in 1964. He sailed on a boat from Nigeria and ended up in Liverpool in the docks. And it took approximately about a month to get here by boat. And on the right-hand side, the top right-hand side is me and my mother at the NHS anniversary celebrations. And on the bottom right-hand is my family, my sisters and my mum, when my mum got her British citizenship. So I come from really proud stock. My dad was really strict, and he instilled that sense of discipline in me. So why did I want to be a nurse? I was a sickly child when I was small, and I was often in the hospitals, and that kind of fed my interest in the hospitals. I loved the smell, the sense of cleanliness and freshness, and I felt really safe. So what is it about me? So I'm a Christian. I will keep my age a secret. I'm from Nigerian stock, as I mentioned earlier on, and I've got a really supportive family. I'm the eldest child, so I tend to be a bit bossy. And I started my registered nurse training in 1989 and I qualified in 1993. Didn't pass my training the first time round. I passed and got my qualifications on the second time round. I'm caring, I'm diligent, I have a sense of professional pride, and I also have a sense of professional responsibility to the nursing profession, but also as a Black nurse. I'm homegrown. I initially qualified in oncology, and then my career took me to the intensive care unit. And this picture shows me in my first year of nursing. So this is my career pathway. It's a very unusual career pathway because normally it's not as smooth as this. So I started as a junior staff nurse in 1993. Within a year, I progressed to an E grade, which is like a band 6 now. And then I progressed on to an F grade. I mean, I think at that point when I was an F grade, I wanted to be a teacher, a clinical teacher, because I took responsibility for the junior nurses. I applied for the F grade, which is like a junior sister, at least twice. The first time didn't get it. The second time they tried to dissuade me. And I actually said to myself, you know, if I'm good enough to be on this unit, then I'm good enough to be here. So most of my career, if you can see, from a D grade to an F grade was on at UCLH hospitals, and that was in the intensive care unit. And at the time, the intensive care unit was a mixture of general intensive care patients as well as cardiac patients. And I absolutely loved every ounce of it. I didn't get a BSc at school or college, so I needed to do a BSc Access course because I was really determined to do and get my master's. And so I acquired my master's in human physiology because I thought my career was going to lead towards teaching. I then came back to clinical practice whilst doing my MSc, and I got a post as a research sister where we did some seminal research on a new antibiotic called linezolid. After I finished my secondment as a research sister, I came back to UCLH and eventually ended up in the Heart Hospital, which was the cardiac surgical hospital within University College London. And once again, I would say that was the best job that I've ever had. I actually took up the post of practice development sister. I did that for a couple of years. And then I was seconded to the London South Bank University, where I ran the critical care course. Not soon after I finished my secondment there, I was asked to join back at the Heart Hospital as the matron for the division. And I think that's one of my proudest moments, leading the Heart Hospital to be a beacon of fantastic practice, not just within the trust, but across London. And I call myself a bit of an ambulance chaser, so I love the drama of that fast-paced critical care and cardiac specialties. And then you can see that I progress through the band 8 grading. After my matron's position, I became a divisional senior nurse, where I led surgery, looked after surgery, outpatients and cancer. I then was headhunted to become a director of nursing in the private sector, a very different experience and one of my toughest jobs because the buck stops with you. I got quite a bit burnt out during that post, and then I took some time off, and then I came back into the NHS. And I have to say, it's quite hard when you move out of the NHS to actually come back in again. So it took me a while, and I, as well as being associate director of nursing for the trust, I also had within my portfolio community services. I then got also asked at that time to look after one of the hospitals within the trust, which had a really poor CQC rating. So once again, took a second director of nursing post within Barts Health Trust. And then I've moved through the nursing ladder, and I'm here at King's. I've been here since 2017, and I am the associate director of nursing for acute specialty medicine. So that's my career pathway. How did I get there? It was really important for me as a jobbing nurse to make sure that my interest not just lay just within the clinical area, but also lay within outside interests. So you can see on this particular slide, I've edited a chapter in a critical care book. I've been part of a research cohort team around antibiotic. I keep myself abreast of what's happening across the nation and also across the nursing field. So it's really important for me to make sure that I'm a visible presence outside of the hospital and on the national platform. And you will see at the bottom right here, the number of committees, because for me, it's really important that my voice is heard, not just within where I work, but also on the national platform, because I think it's my responsibility also to influence the way the nursing midwifery progresses as well. So I think if you're moving up the career ladder, if you're interested in leadership positions, I think it's really important that you do things outside of nursing. And for me, it was really important to give back. And I met a cardiac surgeon when I was working at the Heart Hospital, and he was quite a feisty surgeon, and we lost touch with each other until I met him again at the Medical Association of Nigerian Doctors. And during his speech in his session, he talked to me about, not just me, he talked about some work that he was doing in Nigeria. And he actually led and implemented a charity to do cardiac surgery in a region within Nigeria called Enugu. And he'd been running the program for several years. So I actually got an opportunity in 2017 to go out with the team, and the charity is based in Belfast, to go out and work with the team to perform cardiac surgery to the indigenous population. And so you find here that that patients travel all over Nigeria to come to Enugu to come and have their surgery. And at times it's their last shot at life and health. And the things that amaze me is the learning that can take place when international teams go over. It's not always international teams dictating the care. And the staff were absolutely wonderful, but you do need to be innovative. The IP, your infection control is very different to what it's like in the UK. So you need to be thinking on your feet and responding to how they do things over there. And what was really great is that we got that work recognised in an article that came out in February of this year. So for me, when you're progressing up the ladder, it's really important that you have your role models. When I was coming through my career, there was only white senior nurses. There was no black chief nurses, no black directors of nursing. So I took my role models from historical figures. So you will see Florence Nightingale. You can't talk about Florence Nightingale without mentioning Mary Seacole. And then you have other nursing pioneers from across the pond, Elizabeth Mahoney, you have Ellen Reynard here, and then you have Nigerian nurses. So it's important for me as a Nigerian nurse heritage that I look for role models there. And then on the right-hand side is the current role models. So Professor Jacqueline Dunkley-Bent, the first Chief Midwifery Officer within the country, Dame Donna Kinnair, the President of Royal College of Nursing. We've just had a new appointment, the first ethnic nurse to be appointed for a chief nursing position in the country, Sue Tranker. And then there's Dame Elizabeth Anyonu Joe Myers, and there's just too many to count. This is Francis Fernando, who led a seminal piece of work on the Filipino nurses that died during COVID pandemic. So why is it important for me to talk then around equality and diversity in my career? It's important because within the NHS, we have a very ethnically diverse workforce. So we're ethnically diverse, but so there's lots of diversity, but not so much equality. And so I mentioned in my previous talk this morning that 40% of doctors in the NHS are from a BME background, and 20% of nurses within the NHS are from a BME background. And why do I set this context? Because within the NHS, it could not function without the contribution of its international committees. And you will see on this slide the depth and breadth of contributions from our international brothers and sisters. So saying that, this international diaspora community, it doesn't mean then that everybody is welcome. And there are certain challenges for staff, for any staff, whatever your background within the NHS and the other healthcare settings. But specifically for BME staff, you will see that there are some concerns and their experience isn't uniform. And you will find that equally qualified BME applicants for senior medical positions are less likely than their white applicants to get those positions. Ethnic staff also report harassment and victimization at a much higher level compared to their white colleagues. There's also a degree of unfairness and lack of consistency with opportunities, and it's very challenging to go and progress up the career ladder. And then also staff from ethnic communities are also subject to higher than normal behaviours around discrimination, bullying, harassment, and disciplinaries. And so you would think then that there should be an equal playing field. But this is a piece of work, some statistics that Baroness McGregor Smith did in 2017. She looked at race in the workplace. And you will see that on the left-hand side, the purple is identifies the qualifications, and the purple is the degrees that people from different ethnic backgrounds have. And if you look at the purple, you will see that people from Indian backgrounds, from Chinese, from Asian, Black and Caribbean, they have higher numbers of degrees compared to their white or other ethnic group backgrounds. You will see this here. And yet that is not reflected in career aspiration, career progression, or treatment. And it also, that previous slide was a race within the workplace. If we narrow it down then further, this is what race looks like when it comes to the nursing midwifery profession. And the top graph here is nursing and health visiting grades across the NHS. And the red bar is the BME staff. And you will see that as you go up the bands, so as you go up the bands is progression, you will see that BME staff are clustered in the lower bands at band 5. And this was from, I think, 2019. So this was for nursing and health visitors and midwifery. Then the bottom graph is for all the staff, irrespective of the discipline, and you will see the same patterns. BME staff are in the aqua blue, and they are clustered in bands 1 to 5. It is important because I would imagine that we want staff that feel valued, we treat them well, and then they care, the quality of care goes up. But that's not always the true picture. And this is the recent results of the National Staff Survey, just released a couple of months ago. And within the NHS Constitution, we have 9 protected characteristics. based on gender, religion, race, age, disability, sexual orientation, and other reasons as well. And this, these figures equate to 13.1% of staff out of the survey, and this I think it equates to over 500,000 staff. And when you looked at all the 9 protected characteristics, staff consistently report that discrimination is the worst characteristic for, that race is the worst characteristic for discriminatory behaviours. And that is really, really concerning. And if you look at the line between 2019 and 2020, it's actually got worse. So that tells us that race discrimination and discriminatory behaviours towards staff has worsened in the last year. And I say this in the context of Black Lives Matter. Most people will be very aware of the murder of George Floyd. And it gave us the opportunity, not just in this United Kingdom, but globally, to talk about race. And the amplification around the discussions around race has never been as high as before. And I hope that translates to a better experience of not just staff, but their communities as well. And so we come back to nursing here, not just in this country, but globally. And the Chief Nursing Officer of England, Ruth May, has some really key priorities for the nursing profession within this country. The first one is around workforce, so making sure that we recruit and we retain the right type of people, that we fill in our vacancies. We're sitting around 40 to 50,000 nursing vacancies, nursing midwifery vacancies in this country. It's important that as we bring staff in, that they are treated well, that their health and well-being is up front and centre. And we also rely on international recruitment from Philippines, from India, and you know about the issues in India at the moment. So it's important that as we rely on international communities and their contribution, we need to make sure that they are afforded equal opportunities for education and development. The second priority is around nose communicable infections. So this is around the control and the spread of flu, influenza, but more importantly, COVID-19. And we saw, especially during the first and second wave, lots of cross-transmission within the healthcare workers, and we saw lots of deaths, and we saw lots of nursing and midwifery deaths that I've never, ever seen in my career. And then the third priority for the Chief Nursing Officer is around health and well-being. So making sure that staff have access to appropriate psychological therapy, that they feel safe, they have psychological safety, and that the pressing issues of concern, especially from nurses and midwives from ethnic communities, is that we have culturally sensitive psychological therapies, that staff have a safe space, that they can speak openly and transparently, and that also that we respond to the matters of concern that are emerging. And that is particularly important for me as the chair of the Chief Nursing Officers BME Strategic Advisory Group. And it's important that the work streams around ethnic nurses and midwives is really on point, and it addresses the issues that have been raised. So thank you very much. And that is my, my summary of my career. Thank you, everybody.
Thank you, everybody, for those excellent presentations, extremely informative and emotive too. Pulled at my heartstrings. There have been some questions come through, a couple for Tara. So have a little look. So there's a question from, I hope I'm pronouncing this right, Exaolu. Tara, how did you manage the chest opening emergency in CICU? It's the first question.
Hello, and thank you for the opportunity. Just before I answer that question, Maddie, can I be a bit cheeky and say to Felicia,
not at all.
Lovely presentation. And actually, Donna is a great advocate of sort of roles and diversity, and trained at the London when I was there, and shares many tales of the struggles that she's had from that point of view, really. So, and she's a real example to us. So in answer to the question, I'm trying to turn my phones off as well. The answer about the open chest side of things is that yes, everybody's trained in terms of, well, firstly, the unit work very collegiately together. And so at the beginning of every shift, there is a role sort of allocation of people to be able to know who's doing what role. And the role for the opening chest falls to either the Reg on call or the ACP. And obviously the best person to open the chest in the timely fashion of under 5 minutes is what we're aiming for. So, and all the usual CAL side of things are followed to make sure that the support network team joins for further intervention. We are very lucky in that, although we work in an environmentally challenged older hospital, we are located very near to theatres, which I think does make a big difference as well. So I think that hopefully answers the question.
There is another question for you as well, Tara. And it is a question again from XIO Lou. Do you have some formal certificates for reviewing chest x-rays? And if you do, how did you get it?
So I'm really pleased to hear that Health Education England and the Royal College of Surgeons are sort of championing the bit for advanced practice and extended sort of clinical competencies. But much of this work has been done by ourselves in the cardiothoracic domain sort of in the last 10 years. So I've got sort of, I suppose, 19 competencies for anybody who would like to have, and it takes you through what you would be expected to meet, and it takes you through with the observer what you're expected to achieve at the end. So they've been circulated to people that have asked throughout the years. But I would also suggest that the Royal College of Medicine have some great X-ray interpreting courses. In terms, and they'll certificate for attend, in terms of the syllabus that's now there for Health Education England, if you have a look, there's some generic and some specialist aspects, so there may be some good information there. I'm finding that a lot of the work that we've done previously has been, either has been taken up by the other agencies, and as a result, there is, different formats out there. So, but there's plenty of documentation that we can share for competencies, case-based discussions, direct observable procedures, mini kits in terms of mini examinations. Hopefully that answers.
Are there any questions for any of the other speakers while we're on, even from our hosts even?
Hi everyone. Yeah. I have a question. I'll let Lisa go. Was it Lisa that was talking?
Sorry, it was, yeah.
It's
put on a Zoom call, isn't it? I have a question for Cyan about your SPPB battery test. Is it something that maybe, I haven't heard of it, but is it something you could possibly do on a video call?
Patient's mobility.
Sean, we can't hear you.
Oh,
we can hear you now, Sean. Oh, no, we've lost you now.
Sorry, 2 seconds.
No, we can hear you.
Is that working now?
Yes.
Yeah, so it's quite a basic test really that you could do probably via a virtual clinic. So it's literally 3 tests, looks at sit to stand. So you ask a patient to do sit to stands and then measure how many they can do. And then you also look at 3 balance tests, so whether they can hold a certain position for 10 seconds. And then again, you look at how fast they can walk over a 4-meter kind of circuit. So it would probably be quite adaptable, especially in the kind of day and age that we are at the moment. And there's some good research into kind of its validity as well. So it might be quite a good option. The other one that we've been using in Cardiff and Vale has been the sit to stand 60 test, which is just looking at how many sit to stands a patient can do in 60 seconds. And again, there's some really nice research into kind of proving whether a patient is kind of high risk or low risk for surgery. So there's quite a few good options. I mean, obviously in the past, we've always used the 6-minute walk test, but that's kind of changed quite rapidly during the kind of COVID outbreak where you don't really meet patients face to face anymore.
Thank you.
Any other questions?
Yeah,
Helen?
Can I ask a question? So thank you to all our presenters. Fabulous, fabulous talks. And obviously this is a new platform for all of us. So as I say, we're all trying to adapt to that. And I think the speed that my brain works at, I almost needed a little bit of a pause to be able to consider what everybody was saying. But my question actually is for Bernie about the new hospital, the hospital move, because I know that was such a massive, massive project. And I think thinking about the new hospitals programme now nationally, we know that there are going to be many new hospitals built, and I imagine that there'll be lots of hospitals and staff who will be thinking, goodness, you know, how do we even start to contemplate this? Two things really. One is there anything published by nurses and by clinical staff about moving services like this? If not, is it something that that the team would consider publishing? And secondly, if bearing in mind what you said at the end of your talk in terms of how actually things went ahead of plan, which was great, but what would be, say, a couple of key messages that you would give to your counterpart in other organisations in terms of doing this? Because I mean, it was phenomenal. And as I said, in our chat, I mean, I wasn't even there then, but I spent a long time at Papworth, and seeing that video at the end, I can't imagine how emotional people felt. You know, it was just incredible. So massive well done to everyone.
Oh, thanks, Helen. I guess looking back, I mean, I said at the start of my talk, you know, 5 minutes wasn't quite enough to do that topic justice because the amount of work that went into it. And I was trying to put the emotion into it as well, because I think for people that have worked there for as long as some of us dinosaurs have, it was quite something. In terms of publishing, nursing-wise, no, I don't believe so. There was a medical student that followed me around quite a lot, and there was some work published on the move. So, yeah, we didn't. I think the thing was that we kind of moved, we settled in. It was hugely different, as you can imagine. For some of you that do know the old unit, we went from a very sort of open unit to a unit that was all individual rooms. So very different way of working. And the staff certainly struggled hugely with adapting to that when we first went over, because you lost that support from your colleagues very much, because you were, you know how it would be when you work in a cubicle, you'd look forward to the next day when perhaps you were out and you were working with the team a little bit more. We went through quite a tricky time after the move, and then we jumped straight into COVID not long after. But having said that, had COVID hit us at Old Papworth, we certainly wouldn't have been able to deal with it the incredible way that we did at New Papworth, because it was built for a pandemic, really, you know. What was the other one, Hel? It was messages.
For other hospitals, for people who are in a similar position in their old and crumbly hospitals that are moving to going to be moving to new hospitals over the period of the next however many years.
Yeah. I think I referred to it because obviously there's so much going on at management level, isn't there, in moving a massive hospital. And I think it's allowing people with that clinical based knowledge on the floor who've got the expertise. My you know, I was lead transfer nurse then, to be heavily involved, because it's your sort of speciality as such. Planning ahead, obviously, there were numerous meetings, huge amount of meetings, and considering everybody, the staff. I mean, it was a massive project. And when you look back, and when I think about the move, the hospital never stopped providing services throughout that move. So literally, Old Papworth, when we stopped, we'd already started at New Papworth. So it was an incredible feat. 2 years on, I've forgotten a lot of it already. But
and
yeah.
How is retirement?
Yes, exactly. And And then I think actually when you've worked at a hospital for so long, interestingly, when a lot of the staff were interviewed about the hospital move and about would they go, would they leave, it was a very, very pivotal moment for a lot of people for many reasons. And many people said, you know, if you've worked at Old Papworth for such a long time, let's see it through to go to a brand new state-of-the-art hospital. Incredible. And I did, 18 months and, I've flown the nest to retirement, which is wonderful. Strongly recommend it.
Don't say that. Thank you.
Thanks, Helen.
Okay, so thank you very much, everyone. We've got some questions coming through on Slido, which is lovely. The first one from Justin Tatara, wondering if you cover CICU and the ACP's FICM accredited. And there's also two questions about the lung ultrasound course. Was that in-house or did you attend an external course?
Okay, thank you. I'll take both of those questions in order, but I'm just I can't be on this platform without saying hi, Bernie. You have retired. That's a really good time to do reflection on what you've done, and I expect to be peer reviewing an article that you've written, definitely. So I'm glad Helen mentioned it because I didn't know whether I could say you'd retired, especially if we're the same age. Anyway, it's lovely to see you and all the other familiar faces that I see. So the first question, Tanya, was around the just remind me.
Yeah. So the ACPs, they're FICM accredited.
So no, actually, they didn't do FICM because we actually have a joint role that goes, as I said, 24/7 across both the areas. That said, we are building into the individual objectives, appraisals, and development for everybody to undertake aspects of FICM. So the ultrasound project has moved away, well, not away, to incorporate, in addition to lungs, echo and other such ultrasound skills as well. So no, they haven't got FICM, and we do have I'm the corporate lead for advanced practice in the trust, so we do have ACCPs in our general ITU, and they are on the FICM course. That university that they're at's brilliant, gives them a great training, but it's not one that we've got funding to use in the apprenticeship levy. So that in itself brings a different dynamic to play. So definitely a skill set though that is I suppose commensurate with that. And then in answer to the second question, the ultrasound project was, we have we've got two brilliant anaesthetists that have worked with us throughout, so Neville Hutchison and Rob Kong. And Rob's got a real interest in ultrasound, so he kind of got people working by the bed, and then the decision to make an assessment tool for it, for being able to perform the procedure, and then assessment tool and capturing the data found, and then the tool to be able to check competency. And then each of the individuals have gone and taught on the medical student ultrasound course. And there's different rooms for different sorts of ultrasound. Those of you that have been able to attend the university day that we've had in the past have also been taught by a couple of them on echo. So what's actually happened is we've now got some support to be able to go on formal course to be accredited so that they can have the certification for that. But I think we're probably doing it a little bit back to front in that we've gone from a home cooked situation and then formal recognition outside. What I will say is they are very good. And, the findings that they find are very particularly useful. And the real thing about the data was that although 84% of the findings were in agreement with the consultant anaesthetist individual interpretation chest x-ray, what I said in the talk was actually additional findings were identified on the ultrasound that hadn't been identified on the chest x-ray. So it's a good move, and it's underpinning certainly one of the team was due to speak at the conference around a bit more detail on it, though I'm not sure that presentation is going to be able to be delivered, but you can contact us directly.
Lovely. And there's a follow-up question by Carol, which was a similar question, but they're interested how long it takes to achieve competence. Is it individual or?
So that's interesting, isn't it? Because if you look at the FICM syllabus, you have to do, from an echo point of view, you have to do 50 echoes. So I think it's been more of a journey, really. I think actually before that level was sort of from lung side of things, in terms of lung sliding and being able to identify sort of the B waves and such like. So I'm probably driven by individuals, but it's more around the opportunity and the regularity. So it's no use doing it and then stopping and doing it. And one thing I would say for anybody who wants to do anything to consolidate their knowledge, teach it. So certainly a lot of the courses that we run from an SCTS point of view give you a great opportunity to check your knowledge if you come and teach it with some support as well.
Lovely. Thank you very much, Tara. So we had a question for Fiona from Claire. Claire says, really enjoyed the presentation. Thank you very much. And she's wondering what were the main obstacles you had to overcoming getting the patient from bed to standing? Was the machine still on? Logistically, what was the process?
So because we couldn't flex the hip past 30 degrees, we had to slide the patient. So we slid them from bed onto tilt table, and then we did a progressive 30, 60 and 90 degree stand. The whole process takes about 15 minutes for the first time. Not all patients manage the first time to get to 90 degrees. Once they've established that, we do some just basic exercises, heel raises, and then we progress to stepping off the tilt table and walking.
Thanks, Fiona. Thanks very much. And then we have another question come in from Lyril, and Lyril is questions for Felicia. Felicia, thank you very much for a wonderful presentation, echoed from me. Are there any measures in place to ensure individual trusts are giving equal opportunities to Black and minor ethnic members?
Thank you, Tanya, and thank you for the question. I mean, there are most of the processes should be under the NHS constitution. Most employees should follow the edicts in the Equalities Acts. And I think what also helps is making sure that people within organisations that have got significant numbers of ethnic staff, that they have a really good BAME network, and that you've got a talent management process and program within your organisations as well. So those are some of the things that help. I think it's also important that so, for example, say one of my organisation at King's, we have a King's International networking group for all the international educated nurses, which provides them with a really good forum for raising really good practice, as well as some of the challenges as well. But I think that the issue around equality and diversity should be embedded in their board assurance framework to make sure that staff are afforded that access and that opportunity. But it's normally fraught with quite a lot of challenge.
Lovely. Thank you ever so much, Felicia. Got a question here from Justin to Tara. If you cover the 24/7 ACP service, do you still work with a SHO FY1 throughout the day, or is it purely ACP and registrar consultant?
So it's purely registrar on call, and the registrars are allocated to their clinic, to their theatre, or one on call, and they actually don't carry an on-call phone. That phone goes straight to the ACPs. There is an FY1 in the anaesthetic side of things that is working in the intensive care. But across the rest of the patients, there's just the ACPs, no SHO, no FYs. And then in the ITU after 5 o'clock, it's the ACPs.
Lovely. Thank you very much. And Chow Liu has asked how can she be involved in SCTS teaching? She'd definitely like to do it. Who would she contact?
Do you want me to answer that? Okay, so just send myself your name and I will forward it to Bhuvna. Bhuvna coordinates all the teaching at the moment, and she and I work as a team together delivering at what's currently the online platforms at the moment. So the next one that's coming up is in a few weeks. It's about to be advertised, but we thought you've been bombarded with too many emails. So it's going to look at nurse prescribing and allied health prescribing in the cardiothoracic domain. It's the second part of the two-part series. It's going to cover antibiotics and endocarditis, routine medication, and then a session on AF, and then a couple of case studies that will be presented by colleagues of mine who want to have that element of their particular sort of portfolios for education, because if you're an advanced practitioner, you need to have that element across all the 4 pillars. They're going to give a couple of case studies that will look to say, you know, what challenge do I meet when I see this patient, and what are my thought processes for prescribing. So when we're back, hopefully fingers crossed, face to face, then all sorts of teaching with lots of support to be able to deliver it as well in the team.
Lovely. Thanks, Tara. That was really helpful. I think, Hene, did you have a question? Would you like to ask your question?
Hene, we can't hear you.
Can you hear me?
We can hear you now.
Yeah. No, it's you know, great to see such an amazing discussion. Very intense, very involved. Everyone seems to be chipping in, you know, to an amazing extent. I'm you know, I just kind of flabbergasted, you know, looking at an amazing session. A lot of innovation. I don't know, you might be aware, I'm the chair of innovation for the SCTS, and really it's important that we do lots of new operations and fancy gadgets and all that stuff, but really guidelines, protocols, new ways of doing things is the real innovation, which affects hundreds and thousands of people. Now, I was just wondering, you know, I have an interest in minimally invasive surgery as well, and we have sometimes an occasion where a patient might arrest in the middle of the night. So one of you presented the SCP role in ITUs and 24/7. There's Tara. I understand Tara presented the 24/7 SCP. Well, so you think there is any room for these SCPs to be trained in surgical procedures like opening and closing the chest in an emergency? I know Joel Dunning does a lot of good courses perioperatively with regards to cardiac ALS and stuff. I guess that could be the next step, or it's work in progress. What are your comments on that, Tara?
So hi, Hene, nice to see you. And you're looking very as if you're doing lots of innovation. Are you doing this from your car?
Yeah, I am. That's innovation.
So that's
trying to prove a point.
Yay. Okay, well, listen, thanks. It's really lovely to see you.
I'm actually on annual leave and I'm out and about. So I'm kind of got my phone here, I've got my laptop here, and I'm streaming directly with my, I don't know what is.
You're putting us all to shame, Hene, in terms of our IT expertise. So
it's a personal hotspot. I can't get into lots of different things, but I'm managing. I'm barely managing.
Yeah, it's nice to see you. So I was watching the session on during the universities on the minimally invasive work that's going on, and clearly it pervades into a lot of the units that we're working in now. In actual fact, I asked the same question. The only way to deal with a minimally invasive sort of crisis is either for the team to go back in through the ports and escalate up in their normal escalation plan, or you need a saw on hand, so to be able to open the chest. And that's the same as if you attend a cardiac emergency in the ED department. You know, if you're not going to be supported by a team that's doing a clamshell, then you're going to have to saw the chest. So you're in a difficult situation there. All the CAL stuff that Joel, myself, Adrian, etc. have done is around the six key roles working in a team to be able to open the chest in under 5 minutes, but it's reopening the chest. So it's following the sternum, the line that is there, and the protocol that's been developed, and then going down the correct algorithm according to the presentation. However, if you need to get into the chest in a minimally invasive, then we haven't gone down that line. You need to put people in, and it is one of those aspects that, you know, it's really worth looking at all the other aspects of the COWS course in terms of the deteriorating patient and all the other deteriorating patient courses that we have, to ensure that hopefully come sort of 8-10 o'clock at night your patient is stable, and you've sort of, I suppose, cautioned against things that are going to go wrong to the best of everyone's ability. And if the patient is unstable in any way, then obviously the team will remain and the support will be there. It's the same sort of rules of engagement in terms of off-site working and being available to come into the hospital. So I don't think you'd make 5 minutes, although our registrars in Brighton are brilliant. Many of them live just around the corner. I can't vote for them in terms of the 5K run and how quickly they can get in. It's pretty, pretty good, and the network works, and the ITU and the ward team are brilliant. We've also got surgical care practitioners who don't do on-call at the moment, but at the end of the day, they they have expertise as well. So it's real MDT working, isn't it?
Yeah, great.
I think there's
okay,
one last
lovely.
question.
I've got another question for Fiona. This is from Catherine. Fiona, do you have a formal assessment process that you carry out before mobilising your balloon pump patients to make sure that they're strong enough to be able to step off the tilt table?
So we do a basic maintenance programme with them as soon as the balloon pump's inserted, just per our protocol. So obviously we need to make sure that they can do a straight leg raise on their non-balloon pump side. Normally these patients, because they've come into the advanced heart failure unit for assessment for transplant, they can deteriorate quite quickly, but most of them will have only been on a balloon pump for 5 to 7 days prior to mobilising. So for all the patients that we've had, there's never been an issue with them standing. It tends to be pressure issues. They may become a bit hypertensive. That's what tends to stop their initial mobilisation. But from a functional capacity point of view, no, we've not had any issues from that. And I thought I'd just put in, one of the physios texted me to say that it's no longer 4.17 kilometres as our best performance by a patient. It's now 6 kilometres in 1 day. So that was just last week. So she just texted me earlier.
Have they got a time to submit for the FCTS 5K? I think it was for the clinicians only. We should start including patients. Okay.
Can I ask whether there have been any problem with kinking of the balloon? I mean, surely there must have been some kinking, not major complications, but the alarm goes off, there's some kinking, and the gas is not going in.
So we've had no adverse incidents during our mobilisation. Occasionally, alarm will go off if pressures change, and then we'll put the patient back into bed. But no, we've not really had any major issues with the balloon pumps at all. We've had a couple of these cited, but no more than normally would happen with someone on a long-term balloon pump. So as far as we can tell, no, there's been no adverse incidents.
Can I ask
I've got a question. Oh, sorry, go.
Sorry. I was going to ask Lisa a question about Macmillan funding. Did you have any issues at all with applying for funding, or did you find the process quite easy?
No, it was quite easy because there's 2 of us in ACPs and thoracics at the moment. We were already sponsored by Macmillan, so we had a lot of contacts, and that really helped because we knew exactly who to go to, and to describe to them what the role was going to be and how it was going to benefit, and the sort of things that Macmillan would want to hear, because we'd already been through the process getting our funding. So no, they were great actually. They were fantastic. They just said, okay, well, just tell us what you need. So we put together a presentation for them and costing, and they agreed it. So it was very good. Yeah.
The main reason,
sorry, I was just going to say, we're hoping to do the same thing for getting a navigator role, initially sponsored by Macmillan and then taking up the funding, because generally it's a short-term funding as a project, and then the department can take up the funding. So hopefully we can do that.
I've only said it really because Macmillan are really good at funding projects. So just for the audience, really, just go for it, apply for these this funding. We actually got 2 full-time staff, band 4s, to fill out the HCAs, and they've been funded for 3 years now. So apply for it, we have no problem at all. Thanks, Lisa.
Yeah. Thank you.
Any other questions?
I have one for Sean, actually. Thank you very much for your presentation, Sean. I was wondering from an ERAS point of view, when trusts have very good integrated care pathways and protocols in place when nurses get people out of bed very, very early, what you felt the evidence was for a physiotherapist? Could it have a hybrid workforce approach or an assistant role, or where the evidence was for a physio in an ERAS pathway?
I think as a kind of MD... Oh.
Yeah, we can.
Yeah, I think as a kind of MDT, we tend to kind of work together with the nursing staff in order to ensure like patients are up and about quite early on. I looked into kind of several different research articles that had been created about physiotherapy in the ERAS pathway, and thought it was kind of worth aiming to, improve patient outcomes further. And I think from a kind of repeating the kind of audit process and the QI project, we were hoping to kind of again even push that further by again making sure that patients are up kind of day 0, walking straight back from theatre, all those sorts of things. So I think it can sit quite well within the kind of MDT role, and also then again kind of promoting from a deep breathing exercises point of view and kind of respiratory and chest care, and ensuring that if we are picking up on any kind of indication of patient deterioration, then we're kind of liaising quite early on with the other members of staff. And I think all of our kind of services have changed massively during the kind of COVID-19 pandemic, so it's just ensuring again that we are kind of making sure patients are gaining as much input as possible, and ensuring that we're preventing any post-op pulmonary complications. Hopefully that.
Lovely. And actually going on from that, Chow Lu has asked for you, Sean, if you have a formal protocol of thoracic patient mobilisation in their post-op pathway.
Yeah, so we were quite lucky actually. We worked very closely with our pre-assessment clinic nurse and also kind of the dietitians, and we were able to kind of create our own pathway. So we've got a really lovely blue booklet that all patients receive at pre-assessment clinic, and we were able to kind of shape that. So we were able to discuss with all the different members of the MDT to ensure that we were getting that kind of process written down, and it was followed really closely by all members of the team. So there wasn't really a specific physiotherapy section. It was kind of more like as an MDT. So it wasn't then kind of enforced on, the physios will get patients up later. It was more, this patient appears really well, wants to get up and, sit in the chair. Then everybody was kind of having a go at ensuring kind of early mobilization, basically. So yeah, we don't really have a kind of formal protocol. Each patient is kind of treated quite differently. If they were coming back from theatre late or their blood pressure was low, then obviously we weren't forcing them to get out of bed at that point. But yeah, it was good, especially for kind of new starters and stuff, that they kind of knew the process written in that blue pathway. And again, we're kind of hoping to keep reviewing this at this point, after the kind of changes that were made to our service.
Right, I think we're at the end of our session. Must thank everybody, our presenters, Felicia, Bernie, Tara, Lisa, Sean and Fiona, and obviously our hosts, Haneid, Tanya and Helen. And I'd like to remind everybody to do the scavenger hunt, go on our exhibitions. I've been on it. I've answered 10 questions already. So I'm hoping to win the prize. And then I must say, don't forget to attend our next session, which starts at 1:30. And that is communication, present challenges and future vision. So I'm going to top up with a nice cup of coffee and join that session at 1:30. So enjoy lunch, everybody. Thank you.
Thank you.
Bye, everybody. Thank you.
Bye.
Bye.